data. Importantly, we are sharing information on method choices, FP method choices among people with disability. And indeed, we are seeing a pattern. Their method choices are slightly different from people without disability. Having that information makes us able to oversee and advise when method choices are not observed. We also support supervisions with our government colleagues to ensure that the PW lens, or a lens to serve for services to serve with the marginalized groups like people with disability and the young people, are within their DNA. And periodically we sit together and discuss how to improve it. Thank you.
Thank you so much, Dr. Moke, for the insight and a lot of the interventions that Gender Health is implementing through the SAP program to ensure that people with disabilities are also enjoying their right to access sexual reproductive health. Thank you so much. The tools that we have developed for screening, for capturing data for disability, really impressive. Thank you so much, Dr. Moke. Now to the last speaker, Adam, and then I will invite the audience to ask questions and all that. But let us hear from our Adam, who is from our donor. Adam, health financing is a core function of health system that can enable progress towards equity in access by improving effective services coverage and financial protection. Development partners like you use aid as an instrument to assist developing countries to meet the national development goals like the universal health coverage. The role of development partner like the British High Commission towards the equitable access to sexual reproductive health services, including PWDs and youth people and young people, cannot be overemphasized. We are also aware that British High Commission is an important convener of other development partners. Now, focusing on resource optimization, what are some of the opportunities that the Tanzania health system can leverage on the to maximize impact and ensure equitable access for people with disabilities in sexual reproductive services? Kari.
Asante sana. Just a few remarks. I think on looking at the DHS 2022, we are seeing that modern contraceptives uptake has gone down from 33% 2015 to 22%, but also unmet need has still remained high and changed. So that speaks we have a work to do as a nation. But also looking at the donor landscape, countries like Yemen, the aid has gone down. UK 2019, we had some cuts, and I think US also, they had a 30% cut in the funding. So it is a truly important question you are raising about financing. This is SRH services, but I think the entire health system. So a few ideas from myself. I think point number one, we should embrace what I could say integration. Tanzania, we've been so good at integrating many pillars of health system, like the information management system, well integrated, DHS2, ELMIS, but when you come to service provision, still we have our work to do. I was so impressed at the program supported by Gender and others. You go there for FP services, but you get gender-based violence screening, you get cervical cancer screening, you get HIV, and STI screening, all under one umbrella. And that's what we want. Because now many donors, they are talking about countries to take ownership. But what system do we want them to take ownership? You go to a hospital, you find a general hospital is here, outdated, and a very brand new facility, offering only one program services, well equipped, well staffed, it's the same hospital, but it's like they are living in two different places. And we are now saying government take responsibility. We went somewhere with 2 nurses and 6 data collectors, data entry clerks. Government staff, there are only 2, but data entry clerks, there were 6, funded by a certain program I don't want to mention. So I think, let us integrate service delivery. We have a big gap in human resource, in financing. If you can truly integrate, we can sustain that. For example, now, a program like HIV, if we do not integrate, I was working at a Regency. Regency, the same doctor who will see malaria patient, he will see HIV patient, he will see everybody. But in government setting, we are so rich, everything is. But when donors are going, I think we should just try to integrate. And I think in NIMRI, they've done a very good study in Mwanza, and they saw outcomes, better outcome when you would integrate services. So I think integration will save a lot. But again, a broader concept of localization, and here I will speak the place of private sector. I've been working maybe since 2012, and my fair observation in all countries, especially in Africa, for example, the market for family planning commodities, global market, it is only working for donor communities. It does not work for private sector in countries. It does not work for country mechanisms. For example, if today medical store department or maybe CMS Zanzibar, they want to procure Depo-Provera or they want to procure long-term method, they will get price 3 times the one donors can access. So we need to combine efforts, donors, and actually we are lobbying, so that everybody, every country, even private sector, they can access at the same cost. Because we did it for malaria. For malaria, when it came, Alu, the dose was $8. Now it is just below $1. But not for Implanon, not for Jadel, because global markets, the way they are now, it's not sustainable to say government put funding. Even if they put funding, they cannot buy. So it is something that we are truly working, and we want your effort. But another thing, UHI for me, Universal Health Insurance policies, both in Zanzibar and the mainland, I see like an opportunity for us to start thinking sustainability. We need to really include service provision for family planning and others as a part of the package of care. Without doing that, it will not work for a long time. For example, now we appreciate the efforts of government. We appreciate the equity fund that is being designed for the mainland, also for Zanzibar. But again, if people they cannot receive FP services or SRS services there, including people with disabilities, we will not go very far. So I think all of us, let us advocate that UHI design considers the provision of services for all. And again, my last remark, at FCDO and for all other donors, we believe that nothing for people with disability without them being involved. They should be on decision-making tables. If they are not there, you can think very strange things, but for them, because they know their things, they can use very little innovation to bring the changes. So having them on table is a requirement, and I congratulate the people who are doing that, and we truly wish to see more of that in all CHMTs, RHMTs. They should be part of the decision making, because we have seen a lot of innovation coming from involving them from the onset. Thank you.
Thank you so much, Adam. A big clap for him. Thank you. He has highlighted a number of issues, but made emphasis on integration of services, the need to localize, and the role of private sector. And I like so much the first statement that we have ended with, that people with disabilities should be at the center of the planning of all health-related interventions, as they know much better the challenges that they face. Thank you so much, all my panelists, for a wonderful, insight that you have shared with us. And now I would like to invite my co-moderator, Dr. Anna, to take us through the Q&A session so that you give your opinion, you ask questions, you get some clarification from what has been shared here. Thank you so much. Dr. Anna, floor is yours.
Thank you, Frederick. Asanteni sana panelists, and I would also just like to take this opportunity to recognize uwepo wa Dr. Grace Magembe, naibu katibu mkuu kwenye forum hii. Karibu sana na tunashukuru sana. Asante sana members wa PRALG na Ministry of Health, tunawaona hapa. We would like to thank other donors. I see USAID, UN agencies who are here, and the implementing partners na wote mliopo. Asanteni sana kwa kushiriki. Now I will go on taking questions. Kama una swali lolote kwa panelist wetu ambalo ungependa kupata maelekezo zaidi, so far nina mikono miwili, mitatu, minne. So we'll take the first round for these 4 questions and then tutasikiliza majibu na kuendelea.
Yes, thank you. Thank you. I'm Dr. Ayubu Kasato, International Health Committee. So, thank you for your presentation and highlighting on the importance of innovating the policies. So I was trying to think through, and I think I need to contribute on the policies that now we need to build. You know, inclusion is very expensive. Making an inclusive environment is expensive, and so I would suggest that the government do decentralization of this inclusion. Like, you see, when you are starting a business, there are criteria that you need to meet for you to be given the license to do your business. So what if we put like a checklist that every institution must put a % of budget for inclusion of people with disability? I think this will reduce the workload for the centralized service from the government. And then the other thing is most of the decisions are not done by people with disabilities, for people with disabilities. So I was suggesting to emphasize on client-centered, so the decision and the approach to be on the center of the people with disabilities. Because, thank you.
Asante sana kwa swali, natumaini panelist mmelipokea. Kuna ya PRALG. I believe mtakuwa notice au maswali mawili na mtagawana. Asante.
Asante sana. My name is Dr. Lynn Kanyuru. I work at Save the Children. Thank you very much for a very insightful session. Adam, I was reflecting on your comment around vertical programming and the need for integration. It got my mind thinking, in the world where we are supposed to be learning every day, we don't pause often enough to reflect on the lessons we learn from failure. So my question is actually to the entire group. Anyone or everyone, what have we been doing that we need to do less of going forward? Thank you.
Asante sana. Learning from the failures that we don't really speak out, and therefore people keep doing them na tunaendelea kuzirudia. So what are those ones that we can share? Asante.
Habari, mimi naitwa John George, nafanya kazi UNICEF. I really appreciate for the session and the work that you do behind the presentation that you have made. So my question is regarding the human resource for health, especially when we say the people with disability should be part of the decision making, and I mean, like, they have to be part of the decision making. So back in the days when I was in Muhimbili, I remember one of the students alikuwa na ulemavu wa miguu, walimshauri aache chuo aende mlimani kusoma. Nafikiri hata nao walikuwa kwa damu probably. Sasa eventually I'm not so sure what is the policy saying about what when disability. Of course I know you've said is a spectrum. There are some who can work as the doctors or nurses, etc. But then what can we do so that we have the people with a disability intentionally to be part of the healthcare delivery system so that we can facilitate, and the empathy, of course the feeling that people have could be different, especially when you have disability and when you don't have. Kwa sababu nafikiri tunao wabunge with disability, we have walimu na kadhalika everywhere. So what can we do so that we have such cadre, of course such people in the healthcare workforce? Asante.
Asante sana, great food for thought. I hope our colleagues are taking note.
Asante sana. Mimi naitwa Wema, natokea Plan International. Asanteni sana panelists. Swali la kwanza nitalidirect kwa Dr. Nimesikia vitu vingi umezungumzia about ulivyo balance between demand side na supply side with working with people with disabilities and serving people with disabilities. As we know, we always encourage hearing the voices in improving quality of care. Was there design in terms of hearing how they have rated the quality of care that they were given, the people with disabilities that have been served in the scaling up of family planning project that is funded by FCDO? So talk more about the quality of care, hearing their voices, their feedback mechanism, the customer care they've been receiving. Then the second question goes to Dada Mary. We know that the decision makers in the health facility levels from the community side, for the health facility governing committees include a structure that probably that gives decision making and gives advice. Can you talk more on the composition that is already there? Does it include people with disabilities, or what more can be done so that the kamati za afya zinaweza kuweka watu wenye ulemavu katika part of disability? Na kicha tatu, labda kwa kakaangu hapo Gerard, labda kwa summary kidogo unaweza kutuambia nini implementing partners priority ya sasa hivi kwenye adolescent SRH services kwenye watu kusave watu wenye ulemavu? Where should we focus? What more is needed as a priority for ASRH for people with disabilities? Asante.
Asante sana Wema, na very clear, directed to everyone. Final question and then tutairudisha kwa panelist.
Habari zenu. Kwa majina naitwa Wena Bisalami Ali kutoka idara ya ukuzi na wakunga, Wizara ya Afya. Samahani Spika, naomba niongee Kiswahili. Swala langu liko kwa Madam Ana. Madam Ana aliongelea kuhusu shortage ya wauguzi katika kuhudumia makundi maalum. Kwa hiyo swala langu liko hivi: ana mikakati gani ya kuendeleza wauguzi hata waliopo katika sehemu za maternity na sehemu nyingine ili kutoa huduma kwa watu wenye makundi maalum, wakati changamoto nyingi zinatokezea kwa wauguzi ambao wanakumbana na hao watu ambao wanahitaji hao huduma za huduma maalum kama wenye HIV pamoja na walemavu. Swala langu la pili, Madam Ana aliongelea kuhusu shortage of human resource. Naomba kumuuliza Madam Ana anajiandaa vipi ya capacity building ya kuongezea hiyo shortage of human resource. Asante.
Asante sana. I think we'll stop then hear from the panelists na tutachukua another round muda ukiruhusu. Karibu.
Asante sana kwa ajili ya maswali mazuri. Thank you so much. Kwa hiyo ninaamini kwamba panelists wangu mlikuwa mnachukua maswali kwa kadri ambavyo yalikuwa yanaulizwa. Swali la kwanza lilikuwa linahusu kwamba ujumuishwaji, inclusion is expensive, it should be decentralized. But here to me it was like an opinion, but if anyone can chip in and clarify and respond to this comment that has been made by our colleague, Gerald or Mama Mary, can you, or Dr. Moke? Mama Mary.
Yeah, kwangu nimeiona kama opinion ambayo kimsingi itahitaji kunahitaji wizara kadhaa ambazo zinatakiwa kuweza kuhusika, kwa sababu the way nilivyomsikia decentralization in terms of budgeting kule chini inahitaji labda kwenye CCHP kwa watu wenzetu wa ofisi ya Rais TAMISEMI kutoa guidance kwa maana ya wakati wanavyoandaa zile CCHP kuwe kuna inclusion ya people with disability na mambo mengine, yani the budget wise na vitu gani viwe kule included, lakini inawezekanika isiwe natoka straight kutoka ofisi ya Rais TAMISEMI au Wizara ya Afya. Inaweza kaa inahitaji pia kuweza kuwahusisha hata Wizara ya Fedha. So mimi kwangu naliona kuwa angalau linaongelewa, lakini linahitaji namna njema zaidi ya kuweza kushirikishana, wizara kadhaa ziweze kushirikiana alafu zione zinatoa guidance gani kwenye hilo jambo.
Asante sana Mwameri, naona nataka kuongeza, karibu.
Asante sana, labda pengine niweze kuongezea hapo kwa upande kama wa local government. Kuna budget ambazo zimewekwa kwa makundi maalum, upande kama wa albino. Kila council imetenga budget kwa ajili ya dawa, kwa mfano zile lotion, na hii ilitoka kama ni agizo na maelekezo kutoka kwetu kwamba kila council itenge budget katika eneo hilo kuhakikisha kwamba wana identify wale wote wale albino pengine na kuweka budget za dawa, hasa zile lotion. Kwa hiyo ipo, na kwenye kila council huwa tunafuatilia kuona kwamba kama wametenga budget na zinawafikia walengwa. Lakini nimalizie tu pale kwenye lile swali la kwamba kwenye kamati za afya, je, tunaweza kuwa include watu wenye makundi maalum? Jibu ni kwamba ndio, kama wapo katika hilo eneo wanakuwa included. Lakini pia hata kwenye ajira ambazo tunazo, makundi maalum yamepewa pia kipaumbele, na utawakuta kwenye maeneo yetu ya kazi kama watumishi, lakini pia kwenye level za maamuzi, endapo wapo katika hayo maeneo, wanapewa nafasi kama watu wengine, lakini wao wanapewa nafasi ya kipekee, na hasa kwenye hizo kamati. Na hata kuna baadhi ya kamati zipo zenye watu walemavu, na hiyo walikonsida kwamba wote waweze kuwepo kwa ajili ya kufanya maamuzi. Lakini nimalizie kwa lile la shortage of human resource kwa upande wa wauguzi. Kama tujuavyo wote ya kwamba kweli tuna shortage, lakini bado serikali imekuwa ikiajiri watu na kutoka kwa stakeholders mbalimbali. Wengi tumekuwa tukiona tukishirikiana nao, lakini mpaka sasa tulichokuwa tukisema kwa habari ya makundi maalum ni shortage ya wale watumishi ambao wanauelewa kutoka kwenye academic institution na wako katika maeneo yetu kuweza kuwahudumia wenye mahitaji maalum. Kwa mfano, watu ambao wanahitaji hizo sign language katika maeneo kama ya counseling, nilitolea mfano RCH kwenye counseling, kwa maana ya kwamba anaweza akawa na limitation ya sign language au ana limitation ya communication skills, hasa kwa wale walioko katika makundi maalum. Kwa hiyo tunafikiria kwamba uelewa wanakuwa nao, ila namna ya kucommunicate ndio hiyo tunahitaji kushirikiana na wadau mbalimbali pamoja na sisi wenyewe kama serikali, ili kwamba tuweze kutoa elimu sahihi na hasa kwa makundi maalum. Asante.
Asante sana Mama Mary kwa kufafanua. Naona Mboya anataka kuongeza, Dr. Moke pia.
Asante, niomba nizungumze kwa Kiswahili. Ninadhani pia kwa sababu masuala ya ulemavu ni masuala mtambuka, na ukizingatia sheria ya watu wenye ulemavu nadhani ya Tanzania bara ya mwaka 2010 ilitoa mwongozo wa kutengeneza kamati ambazo nafikiri zimetengenezwa, na hizi kamati za watu wenye ulemavu ni jumuishi kuanzia ngazi ya kata, ngazi ya wilaya, ngazi ya mkoa na hadi lile baraza la ushauri la watu wenye ulemavu. Kwa hiyo ninadhani kimifumo, kama hizi kamati zikiwekewa mkazo, baadhi ya vitu vingine kuanzia kwenye ngazi ya kata, kwenye ngazi ya mkoa, kwenye ngazi ya wilaya, kwenye ngazi ya taifa, vinaweza vikawa vinapitishwa kwenye hizi kamati kwa sababu zina ujumuishi wa kutosha. Mimi na ndugu yangu Msigara ni wajumbe wa kamati hiyo kwa mkoa wa Dar es Salaam, lakini tangu tumeteuliwa
na mpaka muda umeisha na mpaka umeongezwa, hatujawahi kufanya vikao vyenye tija. Yaani tumekutana mara mbili tu nadhani. Msigara anaweza kawa ni shahidi. Kwa hiyo nadhani serikali inafanya juhudi nyingi za kutengeneza mifumo, lakini ule utekelezwaji wa hiyo mifumo unakuwa una changamoto. Nadhani hilo ni jambo pia la kuliangalia.
Asante sana, na labda tu hapo kuweka mambo sawa. Asante Mboya, umeliweka hivyo, lakini pia kuna kamati za afya, na nadhani walichokuwa naomba wajumbe pia, apart from hizi kamati zilizoko kwa mujibu wa sheria ya watu wenye ulemavu, kuna kamati za afya kule pia nako kukiwa na uwakilishi wa watu wenye ulemavu itakuwa ni kitu kizuri, na tukiwa proactive kuwatafuta na kuhakikisha kwamba wanakuwa kwenye zile kamati itakuwa ni kitu kizuri pia, wakishirikiana na hizo kamati ambazo ziko kisheria. Dr. Moke, karibu.
Asante. There was a question. What have we learned so far? Allow me to start with that. One thing it was mentioned here, despite our challenges, emphasizing on integration of services can accommodate to address some of the issues of inequality, including enabling people with disability to access services, where otherwise, possibly it wouldn't have been possible. And secondly, is that use of evidence is still not that widespread. We generate evidence from our implementation. How do we use it to inform our planning and the service provision? I think we need to straighten more on that. Those are the two learnings I can say. And there was a question on feedback on quality of services. My response is yes. We do that. In fact, every year we have client exit interviews, which is rigorously conducted scientifically to collect this information, and it informs our programming. At the same time, at the beginning of the year, we engage various groups of people with disability to reflect on what we have achieved previously and what we can do better in the subsequent year. And that has helped us to plan together. On the question, PWD are not involved. I am not very sure, possibly generally, but in the context of this project, people with disability are engaged. You can attest, Msigara is here. He leads our PWD portfolio, and he has helped us to ensure that various groups of people with disability are also engaged. Thank you.
Thank you so much, Dr. Moke. Is there any question that has been answered?
Yeah, maybe if I just add on a bit on the
Yes.
mistakes.
Karim.
Yeah, I think one of the mistakes that people can do is when you just want to reach people with disability without being intentional about it, without recognizing the resources that you have to put in place. Someone said it's expensive. Yes, it's expensive, but then knowing that the population is not that big, if you are intentional, you can do it. But if you just say, this is something that we are going to do and we are going to attract people with disability without having strategies. For example, working with disability inclusive organization, we have like umbrella organization. They know where people are. They know which language to use. That is very, very helpful. And again, when people are there, what are you doing with them? Because it's one thing having them on board, but then are you providing services that are inclusive and responsive to their need? Because you also want to make sure when they come in. So I think we've learned through other programs that, when Scaling Up started, we wanted to quickly scale to other programs, but it was not yielding the results that we are seeing in Scaling Up because it did not have the structures, it did not have the strategies, and therefore it was not really yielding the results. For example, we have our partner here from Zanzibar who are developing curriculum for sports. We are doing this curriculum for young people, using sports to reach young people with education. But that sport, we say let's bring in people with disability. They're not going to play. They're very physical. So now going back, and now saying okay, so for this game, what are the potential adaptation for a person with physical disability, for a person with hearing? Because for some of them you shout, so they don't have a physical disability, but they can't hear. So you are shouting, catch a ball, they did not hear, and you are hitting them. So knowing, you need to adapt. It's just not as easily generalizable as we can imagine. Just because we heard, there are all these needs, things are possible, and then you can easily adapt. Okay, so I think we have 5 more minutes.
People normally act the way they are measured. Yeah. If you don't measure them in this way, they will not act. So no matter the guideline that the government is making, but if there's no way of monitoring and measuring it, things will not happen. For example, our HMIS tools, they are not disaggregated to capture people with disability. It's very unfortunate. So in our program, they capture, actually, I think 3% now of clients they are reaching people with disability. It's still low. We want at least 5. So at least we are able to monitor through the program that at least in gender they've reached maybe 3% of the clients who are with people with disability. But in the mainstream HMIS, we don't capture that information. So with tools available, if we don't improve our HMIS tool, it means even when a child is given birth, the screening may not happen, and we will not be able to track if we are making progress. So I think we can improve on our routine HMIS to include data on people with disability. Thank you.
Mheshimiwa hapa ana dakika 2 za kusema.
Okay,
kwa hiyo
asante.
Dakika 2 hizi nimeliserve kwako Mheshimiwa. Asante. Kwa haraka sana maana kimda upo. Kama hata anauliza kitu.
Amesema tuendelee tu kwa sababu Dr. Grace ataongea.
Okay. Sasa kabla hajasimama naibu katibu wetu kuzungumza nasi kwa dakika 2-3. Niombe tu washiriki kama kuna neno la kuhitimisha, mheshimiwa akihitimisha basi forum yetu itakuwa imeisha. Kama kuna anything concluding remark, just single minute, half a minute, itakuwa sawa. Tuanze na Dr. Moko.
Yeah, kwa upande wangu naomba niongee kwa Kiswahili. Naamini pamoja na changamoto tulizonazo, bado huduma rafiki kwa wenzetu au wenye ulemavu inawezekana. Tunajitaji kujipanga tu. Inawezekana kabisa. Na kwa namna ya kipekee tuchukue hii opportunity tuliyoipata. Serikali imejitahidi kwa kiwango kikubwa, especially kwenye infrastructure hizi mpya. Unaangalia kila kitu kimewekwa. Ni juu yetu kama watoa huduma, kama watu wengine, tuhakikishe kwamba hawa wenzetu wanapata huduma stahiki. Asante.
My call is on change of our mindset and ensure that the aspects of people with disability are included in every level in the society, and particularly in research and development, to ensure the component of people with disability is taken into consideration, so that the results, the findings that are obtained from the research would also inform on the issues of disability, because it's the area which is a little bit not much explored on. Thank you.
Na mimi kwangu nasema vipaumbele vipo kama tunavyo ambavyo tuna focus kwa young people kama kwenye NAIA, prevention of HIV, prevention of teenage pregnancy, prevention of SGBV, promoting the nutrition, keeping boys and girls in school, issue of socio-economic. Navyo ni vipaumbele ambavyo vinawagusa hata hao watu wanaoishi na ulemavu. Kwa hiyo ni issue ya approach, ni issue ya kusema ni kwa namna gani tunatakiwa kuweza kuwa engage meaningful, ili na wao waweze waone kwa kuna namna ambavyo kama ni intervention nini zina respond kwenye mahitaji ya kwao ambayo wenzetu wao wanaweza kana nini. Kwangu naiona kama kuna there is a low hanging fruit. Nilikuwa nimeelezea kusema kuwa we are thinking ku review the adolescent sexual reproductive health strategy. Tunajua kuwa we have the NAIA, tunajua kabisa tumelaunch soon issue ya ile sera ya maendeleo ya vijana. Najua kwa kule kuna vitu vizuri ambavyo umeongelea kuhusu masuala ya people with disability. So having huo mchakato wa kuweza kudevelop au kureview the adolescent sexual reproductive health strategy, naiona kwangu kama ni fursa adhimu ya kuweza kuona ni kwa namna gani issues za people with disabilities zinakuwa ziko included mle ndani. Asante sana.
Asante. Karibu Mama Mary au.
Asante, nashukuru sana kwa kuhitimisha. Mengi tumeshasema, lakini pia ni kwenye hizi training mbalimbali, ni wito wetu kwamba kwa wadau wote tunaofanya nao kazi kwenye zile training, basi tuweke na component za training kwa healthcare providers, kwa habari ya wote ambao ni makundi maalum, na hasa kwenye sign language na maeneo mengine. Training kama hizi kwa watoa huduma nako ni muhimu, apart from those training, the family planning na nini tulizozizoea. Kwa hiyo kwenye component kama hii pia tuweze kushirikiana na wadau mbalimbali kuwawezesha watoa huduma kwenye maeneo yao kuweza kutoa huduma bora kwa magrupu au maeneo haya husika. Asante.
Asante sana jamani, makofi mengi kwa ajili ya panelists wangu kwa wonderful discussion ambayo tumekuwa nayo. Asanteni sana. Na sasa basi nichukue nafasi hii kukukaribisha Mheshimiwa naibu katibu wetu TAMISEMI uzungumze mawili matatu, na tunafurahi kwa kutupa heshima hii kubwa kuwa nasi katika forum hizi. Ziko nyingi zinaendelea, lakini ukachagua kuja kwenye hii. Mungu akubariki. Karibu sana.
Asante. Is there anyone who cannot follow Swahili? If I may know. My sister, can you follow Swahili? You can. So all of us can you follow Swahili? I know you can't. So like 90% can follow Swahili. Inclusion. So I'll do my best. So first let me congratulate the team for a very good discussion. This is one area that is very pertinent to me. Within the PRAG, the President Office, Regional Administration and Local Government, we are implementing 3 important areas. One is health, the other one is social welfare, and the other one is nutrition. So this forum is really very, very close to me, and it is part of what I'm supposed to be doing. So I'm not here by accident. Actually, I was meant to be here. Yeah. Again, I was following very closely. One thing I want to make very clear is that in terms of policy, I think Tanzania, we have the best policy. And these policies are not only in one ministry. We have policies that address people with disabilities in almost all ministries. And our policies are non-discriminatory. Non-discriminatory. It's not about how you look like. It's not about your appearance or anything that gives you access to education, that gives you access to health, that gives you access to even getting married, you know, because those are also social needs. So in terms of policy, we are very okay. They are very supportive. There was a question from my brother there, like, what are we doing to make sure that people with disabilities, they also have access to all those opportunities that are out there, including employment. So the policy environment is very clear. And that's why, even in our employment policy, we have a clause that directs the government to allocate 3% of all the positions for people with disabilities. And we do that. For those who have been following PRAG adverts when it comes to employment, we always put it very clear. You know, we have 3% of people with disabilities, and they have their slots. Because even the way you identify them, the way you interview them, the way you allocate them into various places for them to work, we do consider all that, you know? So I just wanted to make that very clear. So, as most of you have said, people with disabilities, it's a broad group. It's a very broad group. They have different needs and wants. Initially, we were challenged with our infrastructure. But as some of you said, on the government side, we've really tried our best to address this. There is no facility now that is being built without accommodating needs of people with disabilities. We do that. From, the ramps, the moment you enter at the gate, from the ramps, but also our washing facilities, etc., etc. We are doing that. So maybe what we need to do now is, yes, we've come a long way, and now we are here. What are the most pressing needs? There's a sister of mine there who asked, if we are asked right now, what are our priorities now when it comes to people with disabilities? So we should be able to define that. We should be able to tell exactly now what we want. This is a process. It's going to take us a long way, some time. Yeah, we can't say that by tomorrow. So I think from this forum, maybe as we wind up, and probably this could come as our deliberation in the bigger group, the THS report, that now, as far as people with disabilities are concerned, okay, maybe now our pressing needs are these. These are the ones that the government should now address. You can't get all that you want at the same time, because all these interventions, they need resources, and resources are scarce, okay? So every time we should be conscious of that, and we should prioritize our needs, in such a way that even the government and other partners can also come in and see exactly how best to address the needs of people with disabilities. But again, we have a big role to play in terms of sensitizing our communities. I've seen this. Sometimes you have positions, you have opportunities for people with disabilities, but because families are not sensitized enough, they don't come out to grab these opportunities for their children, for their young people. So I think as much as we continue putting these interventions in place, educating the communities, making them to understand that people with disabilities, there are so many things that they can do in this community. There are so many things they can do, yeah? If they cannot be engineers, probably they can be teachers, probably they can do this and this and this and that. So I think we also have a role to play in terms of changing the mindset of our communities, parents, caretakers, etc., to change their mindsets. We've started doing it, little by little, but I think all of us who are here and those who have not attended this session, we have an obligation to change the mindset of our communities. The other week, I think a week before or 2 weeks ago, we had an annual conference for social welfares in Arusha, and I was there. And I challenged my colleagues, the social welfare officers. I asked them, if you go to a health facility, how many people who are physically challenged come to deliver there? You could be having 1 or 2. Is it so difficult to have 1 bed per facility allocated or assigned for a woman who come with physical disability? It's not difficult. It's not difficult. So some things, the mind change is not only in the community, even us, decision makers, but also people who have different positions. It doesn't take much, yeah? Because in the facilities, I've seen some RMOs, DMOs here. You buy beds. Is it not true? You buy beds, You buy labor ward beds, delivery beds. How much does it cost for you to buy a delivery bed for a physically challenged woman? It doesn't cost anything because it is the same budget. It is a medical equipment, whether you call it equipment or a supply, I don't know, whatever you call it, it is the same money. So it's an issue of changing our mindsets. So I asked my assistant director of social welfare that this year, as we are planning, I want to see every facility buying at least 1 bed. We don't need much. We don't need much. Yeah? So if you had planned it to buy 3 delivery beds, make it 2 for the normal women, and buy 1, only 1, for a physically challenged woman. And the thing is, that 1 bed for a physically challenged woman can also be used by a normal woman we are talking about. And again, the issue of budgeting and planning. If you look at the guideline, it's called CCC swap, yeah? The CCC swap. Social welfare, they have almost 3 or 4 areas that they are looking at: disability, women, elderly, children, and I think gender-based violence. So when you're talking about the budget, it's there already, because that's a priority intervention area. Yeah? We don't need to create something else. We don't need it. Because if you look at the CCC swap, the areas of interventions, people with disability is there, because that's a core function of social welfare. It's a core function for social welfare department. Okay? So we do not need to create something new or something in parallel. It's already there. It's just that we are sleeping. We should wake up. Everything that we need to tap on is there. Okay? So this is my call to all of us, that let's come out of our vikakune. We are somewhere embedded ourselves in our little vikakun. But in terms of policies, guidelines, they have already provided an opportunity for us to plan and budget for people with disabilities, regardless of their differences. Yeah, so that's what I wanted to share. Thank you.
Thank you so much. Thank you so much.
Yeah, asante daktari mkuu. Tutakuomba tu Msigara atataka kuja kuwakilisha the asks kwenye appropriate level ya Tanzania Summit, ili iweze kuwa part of the summary of takeaway kama ulivyotushauri. Asante, tunakushukuru mno.
So once again, thank you so much. Anna, you'd like to say something? Thank you so much for coming to this forum. We have a very good discussion, and yeah, we have got a lot of insights together with what the Deputy Permanent Secretary has, reminded us. We are going to work on them. Thank you so much. Have a good night, a good afternoon, and bon appetit.
Thank you very much. Asanteni sana sana. Samani, kabla mjaondoka kuna tangazo.
Okay, thank you. As we can give a round of applause as our moderator and the team and the panelists are coming back to their seats. But also, as we are ending, we shall have a short awareness session, just a brief session, which will be conducted by Tindwa Medical and Health Services. They are going to do an awareness session on how to handle and... Okay. And thank you. We have taken that into consideration. Thank you very much for that reminder. So we shall have a short awareness session on how to handle unconscious patient in a private vehicle. So we invite you to just participate. And also, after this session, we shall be heading to lunch. I would like to also to know if there is anyone who haven't received a coupon till now. You will see the committee team there at the back. And welcome for the next session.
Okay, hello and welcome to this very short presentation on how to safely transport a patient in a normal vehicle. So the major issues that we need to consider while doing the transfer, there are two basic issues that we need to consider. First of all, is the spine itself And second major issue is the tongue. Normally, when a patient falls unconscious, he cannot actually maintain his airway, so normally the tongue just drops down. So when the patient is actually unconscious, he cannot maintain the airway. So normally what we need to do is to make sure that we actually protect the airway by doing